Empowerment Show aims to equip individuals with the necessary tools, knowledge, and confidence to make informed decisions and take control of their lives. It also focuses on ensuring access to essential resources and the opportunities.
Good evening and welcome to the Empowerment Show. My name is Kendall Stevenson. I'll be the host for the show. So I'm glad you guys tuned in. Again, like I said, my name is Kendall Stevenson. I got a couple of people here from the medical field with me today. Glad you guys tuned in. We always start off with by saying that something that we're grateful for. Well, as everybody knows from last week, we talked about my father. My father is not doing well. He's been put into the hospital. Um, he may be on his last leg. The man's 83 years old, and he's an old tough bird. So I like to be grateful that he'll uh, he'll transition well. Again, so like I said, I have two doctors on. One, I have Dr. Fan. Hi, Dr. Fan.
Hello.
And I said two doctors, but Helen, you're not a doctor, right? So let me just slide you in. So exactly
I'm
what are
not. I
you,
have to
Helen?
clear the record. I'm a
Right.
clinical research coordinator.
Okay. What is a clinical research coordinator?
So I work in the oncology half of our clinical trials and research department. I basically liaison between people like Dr. Fan, who are providers on a clinical trial with patients to figure out their appointment schedules, see if they're eligible for the clinical trial in the first place, and kind of follow them and shepherd them through that process of their participation that might be, years long.
Hmm. So what makes a person qualified to take the clinical trials?
It all depends on the trial in question. Most of them have pretty specific criteria for entry. Usually they're specific to not even just a specific type of cancer, but maybe a specific stage of that cancer or
Hmm.
specific treatments that someone has or hasn't tried in the past. There's a pretty large array of ones that might fit all different kinds of patients.
So do you see a lot of patients? Do you get a lot of people to volunteer to take part in your trials?
We do. It's really interesting the mix of all different trials, have different pros and cons or risks or benefits to the patients, and all patients are different and what risks they are willing to take or what benefit they might be looking for in different treatment options. So we have plenty of people that decline because they're not comfortable or they don't like the idea of trying something different. But we have a lot of people who are very eager to participate and really enjoy their experience having the potential option to get a different treatment than they would as part of their standard of care.
Do you find that there are a lot of side effects with the medication that's given to them during these trials?
Most studies, if it is related to a drug, there are some trials that are also based on maybe a surgical intervention, or maybe it's a drug that already exists, but they are conducting a study to see maybe something changes if they give it in a different sequence or a different combination. So maybe we already know the side effects, but they're looking to see if those change based on that. Most drugs do have some side effects, but a lot of times that's also a layer of the research question is seeing, are they the ones that we expect and already know about, or are there any new ones that we didn't? And then they'll update the drug, as follows.
I'm going to get right to you, Doctor Fan. I just want
Oh,
to
that's
ask one more
fine.
question.
It's
So
fine.
so you know, I used to hear one time that they would give a placebo to one patient and they would give the other patient the actual drug. Does that happen now in your clinical trials?
Yeah, so it depends on which clinical trial and what the clinical trial is designed as. There's many levels of clinical trial. So they could call them phases. So phase one, phase two, phase three, and basically you're looking at different uh, question categories. So when you do clinical trials, you're trying to answer a question, a specific question to that will either impact patients' treatments or may lead to discovery of new drugs or may lead to discovery of important patient factors such as genetic mutations that affect treatment, right? So when it just depends. So if there are trials out there where they compare a new drug, or maybe even not a new drug, but a drug that is showing a lot of promise, and they're going to add it. Let's say you're going to do chemoradiation for a type of cancer, and the standard of care is just radiation, and they're going to add this drug. So they add this drug to the radiation, and then the other arm of the trial is a fake drug, so that the doctors and the patients don't know that they're not getting the drug, and then thus bias the outcomes, because you're expecting to have more side effects or something, and so you see it or you document it in a certain way that actually makes you think that it's worse or better when it's really not. And that placebo arm still exists, but it just depends on the clinical trial. There's a lot of different types of clinical trials, and the higher the phase, so phase 3 randomized controlled trials, which are the most common type that are open in places in different types of hospitals, when you're answering the final question of, is this the new standard of care that we're going to establish for patients? That's phase 3. That's like where you're comparing something really groundbreaking to the gold standard that is currently being used, versus phase 1, which Helen can tell us about, is often more like just what's a good dose that's not very toxic. Phase 2 is often more like, this looks very promising, let's take it a step higher and see what we can, see what outcomes we can get. There's many kinds of trials out there, but clinical trials is how we advance treatment, and it is how we advance care in a very methodical, thoughtful way. It takes time, it takes money, and it takes participation. And
Mhm.
so, in some areas you get advancement very fast. So Europe has a lot of fast advancement because clinical trials are very, like, if you don't go on clinical trial, you can't get treatment off protocol. They just don't do it.
Mhm.
And so the clinical trials enroll rapidly there. Children, like 90, I think it's like 95% of all pediatric cancer patients are on clinical trial. And so when pediatric cancer research advances, it advances rapidly, because every child that has the cancer pretty much is on trial, so they can track and see if they can do better. And they're constantly trying to do better.
Mhm.
Um, yeah.
I'm loving that haircut.
Thank you,
Yeah,
Kendall.
right? It's fierce. Yeah.
Right, I'm telling you,
I'm feeling
I'm
very
I'm
fierce with it.
I'm loving that haircut. It says I'm bold. Don't mess with me.
That's how
I
I
love it.
feel.
There you go. So with the clinical trials, I understand we were speaking at one time, and you were telling me that women hadn't been involved in clinical trials until the 70s or the late
That's true.
70s or 80s or
That's
even
true.
the 90s. Up until the 90s, right? They didn't have any clinical trials for women.
Yeah, so specifically for women, this has become a political issue, but it is actually a fact that most clinical trials, if you go far back enough, were primarily created and enrolled men, and women were just excluded. Men of color were often not included. They were like a minority if they were included at all. Women of color, even worse, because women weren't included. Women of color were certainly not included. And that was just how it was. And so a lot of it's not that there weren't any trials for women. Obviously, there have been some very famous ones that are looking at things like breast cancer and like the Women's Health Initiative. But the vast majority of the bigger trials from the 70s, like you say, and even the 80s, they just enrolled primarily men, and the vast majority of data is from there. And we know that the genetics of men and men of color and women of color are actually slightly different. And so um, if you don't take that into account, you're actually not taking into account genetic variations, or just the fact that certain races or certain sexes may present with more frequent genetic mutations that make them have different kinds of treatment options. You're just ignoring it, is what you're doing, and that is detrimental to everyone.
Wow. Well, you said a mouthful there. Helen, I really want to get back to Helen. I'm trying to find a little bit more about these clinical trials and when should I take one? Let me ask you a good question. How many African American men do you have involved, or do you find that they stay away from it and they're afraid of it?
I don't know off the top of my head, like our entire patient population, what the demographics are, but similar to what Dr. Fain is saying, this trend of representation has certainly come from one direction. And I think a lot of patients have, you know, negative, beliefs about what clinical trials are today based on stuff that's happened in the past.
Mm,
Theoretically, we have a trial open and we want to be gathering a population that's reflective of the area we live in, the patients we have in the hospital, but that's not always the case.
mm,
Some trials in particular will have certain, goals. Diversity and inclusion is a huge thing that they are trying to, promote. Obviously, they know it's better for the data. We're
mm.
acknowledging now that we want to have that more complete picture, like Dr. Fain is saying. So things have certainly changed in who they are trying to recruit and having it open for everybody possible.
Mm, 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 mm. Okay, I'm sorry, but that Dr. Fan, I want to ask you, when should a person, I'm 40 years old. You think I'm old enough to go see a neurologist at that time? To
A neurologist?
Not a neurologist, I'm sorry.
Your urologist?
No, urologist,
A
yes.
urologist?
As a
So,
man.
oh, I mean, if you have, I mean, urology is a big field. So if you have urinary symptoms, like you're having trouble emptying your bladder, or it doesn't have to be cancer screening. Urology does a lot of benign things. They're in charge of vasectomies. They're in charge of bladder health. They're in charge of your urethral issues. So urology is a field that does both benign and cancer treatments. And so in terms of screening for prostate cancer, the most common thing is to start screening at 55. African American men and men with strong family histories often start younger because there is a tendency to appear at a younger age in those populations. So you can like see somebody even younger if it runs in your family, because even if you have no mutation, we know that cancers that run in families, they run in families, and you can be diagnosed quite young. Um, so yeah, so you can go to urologist, or if you just have urinary problems, which can start quite young for some men, then you can see a urologist. There's and for the other things that they see a lot of are renal cancers, which are often asymptomatic. So those are a separate category. We won't talk about those. And then bladder cancer. Number one risk factor for bladder cancer is smoking. And the way
Mm.
it tends to manifest is blood in the urine. It might be microscopic, it might be gross, meaning like you could see it. But that's the number one presenting symptom, and they're the ones who take care of that. They're the ones who make sure it's going to be okay.
Well, I think you answered my question. I wanted to know when a young man should step up to the plate and be screened for
Yeah.
prostate cancer. What did you say, 54?
55, 55.
55?
So the recommended screening starting age is 55, but if you are African American or if you have family history, you might start younger. If you have family history, that means that, let's say your father had prostate cancer at the age of 55, you would be recommended to start at 45. It's 10 years younger than whatever the youngest age is, if that age is 55 or younger. So yeah, so if you're 57, then you start at 47. You start younger. African American men, I think it's a little bit softer. There's no like definite case, but for 40, probably not unless you're symptomatic, or like I said, if you have a family member who was diagnosed at 50, you would come at 40. But otherwise, a little bit younger, maybe than 50, maybe 50 as opposed to 55 would be very reasonable.
Well, it seems that, like in my case, I didn't know much of my family history. So, what do we do for those people who don't know their family history?
Again, the standard would then be 55. But if you're having urinary symptoms, that's something that they take into account at your urologist's office as well. If they're worried, they might screen you sooner. Or, like I said, certain populations, like African American men, they can start screening a little bit younger because it just tends to. There is a slight tendency for more aggressive disease and a slight tendency for younger patients to be found. So it can happen in any race, honestly, but that is the tendency. And so you can get screened a little bit younger. Family doctors will do it, urologists will do it. An initial PSA screen can be done by multiple people.
Yeah, how about that the gene test? Would that help you out, Helen? I think you sent me to go get the gene test, the
Yeah,
genealogy
so
test.
the one that you had done was called the Decipher risk score. So that's specific to prostate cancer. It's not something you'd
Mm.
get done, like if your PSA wasn't at a certain level or you didn't have a biopsy or piece of tissue that proved that you had prostate cancer. But that gives you basically a specific risk score, a number between 0 and 1 based on the genomic profile,
Mm-hmm.
specifically of that person's personal tumor biology,
Mm.
on how aggressive or not aggressive it is, regardless of the stage of the prostate cancer.
All right, ladies, we got to take a quick. I got to pay the bills. Let's be back in a minute.
Hi, we're Chantel Davis and Brian Davis. We own Willie Mays Place and Legacy Vines Winery, located in Gilbert, Pennsylvania. We're open Wednesday through Saturday for dinner and wine flights and really delicious Southern comfort food. Come and join us. We'll happily seat you, your family. We have a beautiful farm-to-table garden as well as 2 therapy donkeys named Freedom and Friar Tuck that you're welcome to come and visit. Give us a call if you have any questions or would like to make a reservation, and we look forward to seeing you.
All right. Hey, I don't know if you guys ever been down to Willie Mays. It's over there on 209. It's in Gilbert. It's a pretty good restaurant, especially if you like Southern cuisine.
Oh, yeah. They have the best comfort food. Yeah,
Oh, they
yeah,
certainly do.
it's hard to beat, you know.
Okay, so a person comes to you, he says, all right, you find out he has prostate cancer. So what are the stages that this person goes through? What's the process?
So when a man is diagnosed with prostate cancer, they do need to undergo some staging and what we call risk stratification evaluation. So the first thing you do, most men these days who are diagnosed with prostate cancer are found because they have a high screening PSA. That's the most common way that men are found today. And it means that men tend to be caught earlier for that reason. So if you have a high PSA, depending on how high it is, then typically in the US today, for modern society, they will go for a special MRI to look to see if they can find a cancer on the MRI. That was not true when I started training, but that is how
Mhm.
we do it today. If they see an area that they think is suspicious, they will set you up for a biopsy, either MR fusion, or if they cannot do an MRI, let's say you've got shrapnel or something, you can't have or a pacer, and you can't have an MRI, you can still have a biopsy that's done under ultrasound. It's just not targeted that way.
Mhm.
And so either way, they need to establish diagnosis of prostate cancer because people can have high PSAs for other reasons. Like if you have an inflamed prostate, an infected prostate, some men have just enormous prostates that make a lot of PSA. And that doesn't necessarily mean you have cancer. So they have to establish that you have cancer by finding that tissue under a biopsy. So that biopsy is done. Uh, you can tell me, but I'm pretty sure you're out for that. You're
Mhm.
sedated, you're not awake. And then you get the biopsy. Um, if the biopsy shows cancer, then depending on so when you find prostate cancer on a tissue biopsy, they will actually give you something called a Gleason score. They will actually look at that cancer and they will score any cancer cells they see on a scale of 1 to 5. 5 is extremely aggressive, and 1 is almost like a normal prostate cell with some mutations. in modern times, all cancers start at the score of 3 and go up from there. So 3 is a well-differentiated tumor, and there's 4, which is more aggressive, and 5, which is very aggressive. So if you have cancer, you get a score. If you have a score of 7 or higher, then that like an actual score, meaning that the first number, they give you like a parentheses, and in this parentheses there's like 2 numbers, and it's like something plus something. The first number in your score is going to be the most common pattern that they see. The second number is the second most common pattern they see. So let's say you have a Gleason score of 7. A 7 of a 3 plus 4 is less aggressive than a 4 plus 3. But if you have a 4 plus 3, that means that your cancer may be more aggressive because you have more Gleason 4 disease. And it is the more aggressive cancer that we believe drives, a man's cancer course. So if you have 7 or above, then you get additional testing, and that might include a special scan called a PSMA PET scan, or for staging, or if it's kind of low risk, 3 plus 4, and there's not much of it, your PSA is not that high. They can't feel anything on the scan on exam. That basically put your stage at 2 or lower, in which case it's optional whether you need to look at bones. In the old days, we used to do CAT scans to look at lymph nodes for spread, and bone scans to look for bones for spread. Prostate cancer's favorite place to spread outside of the prostate is lymph node and bones. So you did that. We have better tests today, the MRI and also the PSMA PET scan, which is superior to bone scans, and so that's what we typically use today, as for most of our patients, unless there's a reason they can't have it. And that's how you get your stage, and something that incorporates stage, your risk stratification. All prostate cancer patients are stratified into low, intermediate, and high risk categories. And basically, that risk that we're talking about is the risk that the cancer, it may have spread, how aggressive it is, the risk that the cancer is not going to be cured with treatment or recur at some time, and your treatment options, and that may be to do nothing. If you're very low risk, you can go on surveillance, and that's okay. Or it may be to do very aggressive treatments because your cancer is very aggressive appearing, and we're going to do multiple treatment options to try to bring you under control. And as long as it hasn't spread out of the prostate, you are considered curable. Um, so that's when options come. Now, Helen's trial, or not her personal trial, but the trial that she runs, is actually looking at something where, in addition to what I told you about for risk stratification, they are looking at the genetics of the tumor itself. And that's what that Decipher test is really all about. So, in addition to traditional ways of assessing aggressiveness, you can actually break down the genetics and the mutations of the tumor itself. And there are companies out there who have developed technologies to basically create a scoring system where, if you have a score of mutations, uh, uh, like below a certain number, in a certain number, above a certain number, then they consider you high risk or low risk or intermediate risk for having more aggressive tumors that are going to fail or not fail with the traditional treatments. This has been used for a long time in breast cancer. It's now how they determine whether breast cancer patients need chemotherapy or not in a lot of situations. It is used in lung cancer and brain cancer routinely. It is more and more being used in GI cancers like colorectal cancers and stomach cancers. And they are bringing it to prostate cancer as well. And so, that's what the Decipher test is about. And that is also influencing how we counsel our patients today.
Right. So I got a couple of questions. The first question is, people may not understand the acronym of a PSA. So what does the PSA mean, and exactly what do you do? How do you receive this PSA?
PSA means, it stands for prostate specific antigen. It is actually a protein created by prostate cells, and it's released into the bloodstream so you can measure it. There are so when you get a level of PSA, these are levels that have kind of been established, through Helen, you can correct me if I'm wrong on this, but I believe it's just historical reference values of what they consider normal, and above a threshold of 4 is traditionally considered elevated, and they will like look into it further to see if you need further evaluation. I will tell you, for like this screening for prostate cancer with the PSAs is like the level, like what is considered elevated is kind of controversial because if you have a big prostate, you might make a lot of PSA. That doesn't mean you have cancer. The 4.0, like we were talking about before, was based on a lot of data gathered from white guys, which is not wrong. I mean, that's who, these are good guys. They volunteered, but it doesn't actually always apply. And so we know that in particular, African American men can have cancer at lower screening PSAs than a Caucasian men. It's just one of these things that happens to be. Um, uh, but regardless of our arguments of the screening, that's what it is, prostate specific antigen. And the PET scans that are done for prostate cancer are not traditional PET scans. Um, uh, you know, uh, PET scan stands for positron emission tomography, which is
Mhm.
basically where you do a CAT scan and then you fuse it to this special scan that looks for radioactive nuclides that are attached to like a molecule that is uptaken by um, uh, like cells. So the traditional PET scan is a sugar molecule with a radioactive nucleotide attached to it, and then you inject patients with it, and then anywhere that takes up a lot of sugar lights up on the CAT scan, and you can see it. For prostate cancer, you do something called a PSMA PET scan, and that's a different targeting molecule. It's still a radioactive nucleotide, but instead of sugar, it's attached to something that hunts down PSA,
Mhm.
and so or PSA producing, cells, and that's why it's used for prostate cancer staging.
Hmm. I think the biopsy may be the only thing that's 100% because I've taken a different test like the MRI and they came back negative. Everything was negative until I did the biopsy, and I think the biopsy was the 100% sure. So I
Yeah.
think that's the only way that you can truly know whether you have this type of cancer, right?
Yeah. Yeah, that
Mhm.
is actually the most important step. Everything else is to check and make sure that it's contained and give us
Mhm.
an idea if you need to move on to biopsy. But you cannot be diagnosed with prostate cancer without some type of tissue. And especially if it's early, there are people who come to us who have widespread cancer everywhere, and their PSAs are in the tens of thousands. And we still get tissue, but to establish, but it's in those situations it's probably prostate cancer. But for people, if your PSA is rising and it looks and you can't find it on MRI, that doesn't mean it's not there. It just means it's hard to find. And the biopsy is how we establish diagnosis.
Okay, Helen, can you ask me how many different types of cancers are there?
How many types?
Of cancer, there's how many different types of cancers are there?
Gosh, I don't know the answer, but it has to be high. I mean, if you think about most major organ systems, we're talking about prostate, breast, moving to areas like bone, blood, those are hematologic malignancies. Basically, not an endless number, but there's different kinds of cancers for almost every organ that we have. And then they are getting more and more not specialized, but these subtypes, like how Dr. Fan is describing the, risk groups for prostate cancer. So of one cancer type, we're getting more and more finessed with what categories of that type of cancer. So that number is probably very, very high.
Mhm.
you know
Are
there's
there any cancers that can't be cured?
oh yes.
Like what? What type of cancers can't be cured?
Unfortunately, there's quite a few of cancers that are highly lethal. GBM is considered basically incurable. Glioblastoma multiforme is its full name. That's the cancer that Joe Biden's son, not Hunter, the other,
Hunter Biden.
no, the one who died, Bo.
Yeah,
So
both.
yeah,
Mm.
so he died of glioblastoma multiforme. Those cancers are very, very difficult to treat and tend to be almost universally lethal after a few years. There are some rare brain cancers that grow in the brainstem that cannot be treated, and basically, if you have one of those, you will die. Um, there's a lot of pancreatic cancer remains highly lethal today. Um, it is very difficult to treat. It is very difficult to cure. It is very difficult to find early enough to cure. But some strides have been made there. There are incurable diseases.
Yeah, from what I understood, I think there's like over 200 different types of different cancers that you can receive. But the treatment now, radiology, is that radiation? What other types of treatment can a person receive?
Well, so for prostate cancer, depending on your risk category, you can have different types of treatments. But basically, the you know the sort of the standard of care bulwark treatments fall into either if you're going for curative treatment, then it's typically either surgery or radiation. And there's many types of radiation. So there's external beam radiation, which can be delivered in a traditional way, which is once a day, 5 days a week, Monday through Friday, anywhere from 6 to 9 weeks, depending on your situation. 20 minutes each day. That is a very common way of delivering the radiation. It's been around for decades. It's gentle and it's effective. The other way of doing radiation is doing internal radiation, where this used to be called the seeds. It's now called brachytherapy because in the past we would actually drop radioactive seeds into people's prostates. But a lot of places don't actually leave seeds anymore. They just treat the prostate there with a machine, and then the needles that deliver the radiation are removed, and there's nothing left over. So now it's called brachytherapy. The technique is the same regardless, which is internal radiation using needles. It's usually done under general anesthesia. You go into the operating room, and people will put these thin, fine, long needles through the perineum, which is the skin between the scrotum and the anus, and that's where your prostate lives. They put the needles into there, they deliver radiation. The radiation goes from inside out as opposed to outside in, and then the needles are removed, and you go home, and your prostate cancer has been treated. It's much shorter. It's a very high dose of radiation that's delivered at once, so there is a kind of slightly different profile and risk categories. Like you have to be up for this type of treatment. Um, you have to qualify because there are some things that will disqualify for you from this type of treatment. The advantage is that it's one, like I said, is faster. It's a higher dose at once. But uh,
I tell you this, I wouldn't qualify.
no, there are guys
No,
who
no,
like
no,
if
no.
your prostate's
You
if your
said
prostate.
needles. You said sticking needles into me. Sticking needles
Kendall's
into
least
me.
favorite thing.
No, no, no.
So I mean, you're not awake for it,
Yeah.
but
Okay.
you can wake up with a catheter, and then it comes out
With a
when you
catheter.
yeah, because you have to have
How
a
long does that
catheter.
stay into you?
Oh,
How long?
they take it out as soon as you wake up. So
Ooh, that must hurt.
ideally, yeah, to go home you have to get the catheter out. Otherwise they keep you overnight.
That sounds very painful.
If you can't get it out, yeah. But if you like most so you're screened for these procedures to reduce the risk of that happening. But that is one of the risks when you do brachytherapy. The advantage of doing inside out radiation is that the radiation doesn't have to go through normal tissues to get at the target. The prostate sits in the middle of your pelvis, so you've got to go through tissues to get to it if you go from the outside in. If you go from the inside out, then the prostate radiation just doesn't spread very far. That's the nature of brachytherapy. And so you can deliver very high doses of radiation, much higher than what you can do from the outside in, until more recently. So technology has, brachytherapy has been around for decades, but what has come onto the scene or kind of roared onto the scene as an alternative to brachytherapy is stereotactic body radiation therapy. This is also known as SABR treatments. It's not spelled SABR, but it's SBRT or SABR treatments. And that is where you're kind of doing the same thing. With modern technology, you are now able to do basically high dose radiation to the prostate. And instead of doing like 6 weeks or 9 weeks of radiation, you do all the radiation in 5 treatments.
Mm,
And it's from the outside in. So you do have to have special devices for this, like something called a space or gel that separates the prostate. You have to have markers in your prostate for targeting. It's very like target oriented because it is an extremely high dose of radiation being delivered from the outside in, which can be dangerous if you are not careful. Um, but this treatment has been shown to be at least equivalent to like 6 weeks of radiation at 5 years for lower risk patients. You have to qualify for this just like you have to qualify for the needles if your prostate's too big, if you have a lot of problems with urination, if your cancer needs pelvic radiation to include lymph nodes, then you do not qualify very well for this type of treatment. It is
mm,
mostly for people with smaller prostates who are interested in shorter course treatments, who are okay with like really kind of acute side effects that might last with them for a little bit,
mm.
um, but do get better over time.
Yeah, but
Um,
I think it's because we live in a microwave age. They want to come in, they want to get done quick, and they want to get out. I had a couple of
yeah,
buddies of
yeah,
mine. They had
and
taken the what do you call it, cyber knife? I think that's what you call it because they
CyberKnife
went.
is so CyberKnife and SBRT are the same. CyberKnife is a brand name using a specific machine to do SBRT. So they are the same technique. So we do Saber radiation with a brand name machine called the Ethos machine is our favorite machine to use for this, which will do like basically live targeting for each treatment because it's only 5. So they do like live checking of target. If it's off, they can actually redo the plan there before they deliver the radiation. And for like these very high dose treatments, it's our favorite machine to use for this treatment. They have an alternative treatment machine that doesn't have live targeting but has like super targeting because they use it for SBRT of like spinal cord tumors.
Mhm.
So it's also an excellent machine to use for this. Yeah, so there's different types of radiation. You will also hear about other types of treatment. There's always something cooking for prostate cancer. So in the past, it was HIFU, cryo, and now there's got some kind of laser, which I forget their brand name for, but there's always something on up and coming for prostate cancer. HIFU and cryo are not used up front typically for standard of care treatment of prostate cancer. They talk a lot about it. It does have its role. They usually are used more for salvage because these treatments are associated with poor control. They don't have as high cure rates, and
Mm,
they have their own toxicity. So if you're going to do it, then I don't see an advantage to doing the inferior treatment if you're going to do it. But they definitely have a role for salvage. And there's like a new laser out there now for ablation for prostate cancer. It looks pretty promising, so hopefully
mhm.
it'll have a better outcome than what some of these others have had in the past. But yeah, you always hear about alternatives, and they exist, but they are not standard of care for a reason.
I heard you say the word chrono. Is that what do they freeze the cancer or
Yeah,
something? Or
cryotherapy.
yeah,
So
cryotherapy.
yeah, so cryotherapy was very in vogue when I was in training, and people were doing a lot of it. But it turned out that cryotherapy has inferior control, like cancer control. And when they started it, there were all these problems with it. But yes, you basically freeze the prostate. And when they first started, they were freezing the entire prostate, which would then basically ice over your urethra, and people were like 100% incontinent. There were problems with it. So then they started doing, so to overcome that, they would do something called urethra warming, which they still do today. And basically, they keep the urethra warm and then they create ice balls around it. But if you try to treat the entire prostate with to become like an ice ball, and you just kind of keep the urethra warm, you cannot control ice crystals very well, and so you do end up with like this rim of frostbite, I guess, around the prostate. I mean, I'm not a cryo person, so I don't know all the details. And I got to tell you, good cryo for salvage is some of the best out there. But in terms of like trying to treat the entire prostate, it was not particular. Like some people are still doing it today. And in modern hands, doing modern techniques, I think there's a lot less toxicity and it's considered an option, but it is not a standard of care option for first line treatment for like on like guidelines, and that is because it is an inferior treatment compared to radiation or surgery um, for that type of thing. So
Well, I'm glad I did it the way I did it.
yeah.
If it was the old fashioned way, it was okay with me to take my treatments every day, to come down and say hey, and I felt much better with that, mentally and physically. And you
Yeah.
know.
Yeah,
Hmm.
so I will tell you that even though it's like the way we treat is the same, the doses have gotten higher and the side effects have gotten better. This has to do with the improvement of technology, and pretty much that's it. Like, our machines basically today, the computers and the programming have advanced. And with that, our ability to deliver accurate and precise radiation targeted each day has gotten better and better. And that has resulted in increased cure rates and lower toxicity rates doing the same thing that we've done for the last 20 years because we're just, well, not me personally, but the machines are better at it, right? So.
Have you found anyone or patients that have taken the treatment, but because it's radiation, they've had long term effects?
Yeah, so this is a real thing. You have radiation does not come for free. Long-term radiation toxicity does occur. It's thankfully not very common, but it does happen. And so this is one of these things where radiation is a known carcinogen, and it leaves behind changes that may take time to manifest. It's very different than what we think of when we think of surgery. So when you do radiation, you're going to deposit some radiation into the tissues around your target. So for prostate, it's typically like rectum and bladder are the closest things. And so there is a very small but real risk of something called radiation proctitis. We see a little bit less of these days, but that's basically years after the radiation has occurred, you can have like a bright red bleeding in the stool. And sometimes it's associated with diarrhea or like sort of like inflammation of the bowels or rectum, which can make it, is usually treated with medications and like suppository foams to calm the inflammation down. In most cases, it's painless and it's not dangerous, and it does get better in a lot of patients with conservative management. In a few cases, it can be quite detrimental. But what is actually more severe and more rare, or at least it used to be, is radiation cystitis. True radiation cystitis is quite horrible. It's basically this bleeding, scarring disorder that can happen in some men who've had high dose radiation exposure to their bladders. It can cause what we call progressive scarring and bleeding into the bladder. It's difficult to treat. It often gets worse on itself. Eventually, it can lead to a scarred bladder that no longer works, but does cause pain and bleeding. And that's treated with things like hyperbaric oxygen, conservative management by urology. Like, they do cauterization for the bleeding. But radiation cystitis also often happens years after your exposure and it's a bad outcome. Luckily, it happens in 3% or less of our patients, and as time has gone on, that number has declined as well, just with like I said, improved technology. Not because we've done anything fabulously different. We are very aware of it, though. It is something we uh, worry about. And you've been through this, Mr. Stevenson, where we ask you to fill your bladder for treatment. That's to push
Hmm.
your bladder out of the way. It is the most challenging part of treatment for most men because it's hard to fill your bladder every day to
32
the same
ounces.
amount. Yeah, it's a lot of
Thir-
water. It's a lot of
32
water.
ounces.
But that's part of our strategy to try to push more bladder out of the radiation field. We're trying to protect you from this, so we don't skimp on it.
I can say you guys do a fantastic job. I really appreciate you guys coming on. We're coming to about the end of the show. We usually only do about 30 minutes on this show, but as you can see, we're already at 45 minutes. So the information that you guys have been giving out has been fantastic. And again, I really appreciate you guys coming on. All right. Helen. Hi,
Thanks so
Helen.
much for having us, Kendall. Hi.
Oh, Helen, before you go, do you want to tell them about the Exact Science trial? I think that trial might be interesting to his listeners. That's a very interesting
Sure.
trial.
Yeah, if we have a few more minutes, it's one of the highest enrolling trials that we have currently. Like Dr. Fan was saying, that some clinical trials aren't about treatment, but are about finding things with genomics or related to cancer detection. So, Exact Sciences is a company that makes a lot of different products. Most people are familiar with the Cologuard test. So, that
Mm,
instead of getting, again, if you meet certain criteria like risk factors and your age, for some people, they can submit a stool sample to this company, and they have discovered through other research a set of gene panels that basically can indicate that there's colon cancer earlier, as opposed to getting a colonoscopy and having the invasive procedure. So, a lot of people are familiar with that as another option, but what they would like to do is make more screening detection methods like that for other cancers that we only have invasive methods, or maybe are catching it later through screening than we would hope to. So right now we
mm,
have a trial open that essentially all we ask of patients who have a new diagnosis is to let us take a look at a piece of their tissue from the biopsy that they use. So it might be the one like for prostate, um, to initially see what type of cancer you have and confirm it, and pair that with a blood sample to see what biomarkers might be present between those two samples. So, a biomarker could be something like a fragment of DNA, it could be a protein that's expressed, a number of like biological molecules that might be an indicator that the cancer is there prior to having any treatment.
okay. That sounds excellent. Sounds like we're on a winning team here. Just want to ask another
That's
question
right.
about the prostate cancer and pretty much cancer in general. When in early detection, what do we consider early detection? Let's talk about not just the prostate. How about the colon cancer or the mammograms for women or the different type of testing? How early should we be tested?
So the screening age, and you can correct me if I'm wrong, Helen, but the screening age for so colonoscopy screening age is now fallen to 45, and that is because the rate of colorectal cancer has gone up over the years, and it is coming younger and younger, like every year. So it used to be 50, now it's 45 you start. And uh, the ideal is to do a colonoscopy. Everybody hates the colonoscopy, but it's also honestly like um, it's like the the only test where you get um, potential treatment and screening at the same time. Because if they see a polyp, they will remove it. And so that polyp never has the chance to become cancer. If it's got cancer potential, it's gone. So, that's the trade-off you get. You don't have to you don't have to go for a prostate biopsy. It's done. You don't have to go for a breast biopsy. It has been done. So if you look at it that way, it's more efficient. But yeah, the Cologuard test is a good option for patients who maybe it's not so easy to do a colonoscopy because of their, they don't have time for it. They don't have like access to it. They're on blood thinners or something. It's a huge deal. Then that's a good test, and your family doctor can guide you and use that as a starting screening test. But the age is 45. For mammograms, the age has also fallen. So starting mammograms can start as early as 40 now. And that again, because we are seeing women with younger women with breast cancer than what we used to. There's a growing cohort of women who are younger who are presenting with breast cancer. This is not a good trend, but it is something we're seeing. So starting your mammograms. Mammograms are not painful. They are very uncomfortable. But they are, they take about maybe 30, 40 minutes at most. If everything goes well, you can get them like, once a year. And let me tell you, if you catch a breast cancer early, you have lots of options. If you catch a breast cancer late, you are going to go through a lot of treatment because you need it. And that is not great for you. It is not something we want for you. So, yes, the mammograms are not fun. Yes, the mammograms, they're kind of inconvenient. But if you catch your cancer early, your cure rates are high, your options are many. You could potentially get away with not doing all arms of treatment, but you catch cancer late, it's spread, it's aggressive. They're gonna throw the kitchen sink at you. You're gonna be offered everything. You might have, you really should consider it. And they got like lots of drugs, lots of surgery, radiation, more drugs, all in hopes to protect you. But if you catch it early, maybe some of those things can be tapered off a little bit depending on how old you are. If you're young, you're pretty much going to get everything. But if you're older, you have options. And even if you're young, you have options. It's better. It's better to be caught early.
All right. So early detection is the key.
Yes, you will do. It'll be better for you.
Right, right. All right, ladies, again, thank you very much for coming on. I do really, really appreciate it. I think you had another doctor that was going to come on. The name was Stone.
Smith, Dr.
Smith.
William Smith. He actually is the head investigator at our hospital for the prostate cancer, and he leads a couple of brain tumor clinical trials. He was really looking forward to this actually, but he had some family things come up, and so he couldn't come today.
Oh, don't worry
But
about it. You know
yeah,
what you can do, ladies? You can bring them on next time.
yeah,
How about
That's right.
that? All right, you can bring them on next time, and this way this way you'll have two guys, two girls, and we can chop it up, as they
yeah.
say. All right. All right, ladies, it's time for me to go. So I got to say goodbye. And thank you
Thank
very
you.
much for coming on. And thank you guys for tuning into the Empowerment Network. My name is Kendall Stevenson. This is the Empowerment Show. And we had a really good time. We got an opportunity to learn a little bit more about cancer. And I think it went somewhere. I think we got something out of it. All right. Kendall Stevenson saying peace. As usual, time to sign off.